Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. My name is Noah Mandel, and I'm a resident physiotherapist from Toronto, Canada. I created this podcast to provide you with educational content, not medical advice. Please seek advice from a qualified healthcare professional if you are currently dealing with a health-related concern. If you enjoyed the podcast, please consider leaving a review. I would deeply appreciate it, and you would also be doing your part in helping the podcast grow so that we could provide this information to more and more people. Hey everyone, welcome back. Today I spoke to Ben Cormack, and it was one of my favorite conversations that I've had about the world of physiotherapy up until this date. If you listened to the first episode of the podcast where I spoke to Adam Meakins, you'll know that Adam recommended that I have Ben on the podcast to talk about the biopsychosocial model. The biopsychosocial model is a philosophy that appreciates the importance and interconnection of psychology, biology, and sociology when it comes to human health and disease. When I say it, it sort of sounds like the common sense approach to human health. You know, of course, humans are complex, and it makes a lot of sense that psychology is important and that human health is not purely influenced by biological factors. Having said that, healthcare, for the majority of the time that it has been around, has been using the biomedical model. This model tends to only look at the biology without focusing on the importance of other factors, and it can be overly simplistic. So needless to say, this model has its pitfalls, which Ben and I discuss in great detail. Ben has been a physiotherapist for over 20 years. He teaches courses all around the world. He has helped to write a few research papers, and he was the lead author in a paper about the biopsychosocial model last year. And he is really knowledgeable. He's kind. He has a lot of profound things to say. He's a very engaging speaker, and as you'll see, he is very funny. So without further ado, I'm going to shut up, and I hope you enjoy.
Yeah, what some people do is they do... Anyway, let's go. Let's start. Fuck it.
All right, we're just talking about how we're going to do an intro later on my own time, and we'll just get into it now. So here we go. We're getting into it now.
Yeah.
Thank you very much for coming on, Ben. I really, really appreciate it. I'm really excited to talk to you because your perspective is one I really appreciate. Before we get into everything, though, do you mind telling everyone a little bit about yourself? You know, who you are, what you do, if you have an area of expertise, and maybe a little tidbit about yourself that isn't so related to physio.
Yeah, so what do? I suppose these days, mostly... my role is more educational than clinical, although I've done a shitload of clinical practice. So I run an education company called Cor-Kinetic. I run another online platform with my partner in crime, Adam Meakins, called the Better Clinician Project. I still do bits and pieces of clinical work. And so that generally equals 1 day a week in clinic when I go into central London, and then also various online bits and pieces. I write some papers as well along the way. So I do a little bit of academic stuff. Occasionally I get invited to do a little bit of university teaching. So background wise, in the UK, I studied what's called sports therapy, which is kind of more musculoskeletal perspective rather than kind of all the neuro and respiratory stuff, although I realised that sport is not really my thing, if that makes sense. I found it quite repetitive, and I think, you know, in the world of pain and rehabilitation, there's a whole, you know, bigger world to it, which I've explored since. So what's not kind of, you know, physical, clinical related? I don't know if I'm a big boxing fan.
There you go.
Yeah. So that's one thing that some people know and some people don't. Also, I've spent many years DJing. If you were to look over to my right side, I've got all my decks set up in my room over there. We can see them.
Oh, look at that.
Standing over. Yeah. So I also try to do stuff that's not, you know, kind of clinical related as well, because, you know, that's there you go. That's a little key to the world. So there you go. There's a little bit about me.
That's cool. Ben Cormack is a DJ. I had no idea about that. That's really
Way
funny.
back in the 90s, bro.
True. How long have you been doing that?
92, 93. So,
wow.
Yeah. So I don't know how many years that is ago. What's that, like 29 years or whatever, since I was maybe 15, 16, something like that. So anyone who can do the maths, then you're going to realise that I'm an old bastard. But
what's the genre? Is it hip hop that you mostly do?
No. So for me, it was like house, garage, that kind of stuff. So
cool.
That kind of early rave music and that kind of thing. There you go.
That's awesome. Very cool. Okay. But I'm guessing that you don't have a ton of time to do all that stuff because as we were talking about before we started recording, you're quite the busy guy traveling around the world, teaching your courses and all that.
Oh yeah. My decks of dust collectors. Yeah. They just collect dust. Yeah. So I really enjoy, the traveling and the teaching. I actually think I'm a much better teacher than I've ever been a clinician, if I'm honest. But but there you go.
Good to know. Do you are you still enjoying that one day of clinical work that you have a week?
Yeah, look, I enjoy it even more actually than I used to. So I don't always enjoy getting on the train for going into London for an hour and that kind of stuff. But then equally, I like to be out and about, and I love to meet people and just making sure that I'm keeping alive to all the different, when you talk about stuff a little bit theoretically, I think it's also good to have an idea about, how those things land and they apply and the curveballs that get thrown at you, So evidence is one thing, clinical practice is another, and then somehow we have to find a little bit of a middle ground, I think.
Got you. Yeah, that theoretical stuff, it always sounds great to the physios and everyone probably soaks it all in, but sometimes it's a little bit different in the clinic, right?
Oh, look, but that's something that I think we need to discuss about evidence, isn't it? We need to discuss that, what happens in a research paper isn't reflective of every clinical situation. But at the same point, it can also guide us in a clinical situation. And I think people love to be binary. They love to say, well, research doesn't reflect the clinic, or they like to say, well, research says this. And actually, one of the big issues about, doing this role and working with people is it's a blend of both. It's being able to take this population level information that guides us, but be able to roll with it and adapt clinically in any given situation.
Right. Yeah. And even people who are arguing against certain stances make it binary as well. Like people who argue against the evidence-based community will strawman people in the evidence-based community and say things along the lines of, like you can't be so black and white in your practice. You can't do things that are only in the research. And most of the time, evidence-based clinicians aren't operating from that standpoint. We understand that things aren't black and white, and research provides averages and not exact guidelines of what you can do for every single person that comes in the door, right?
Yeah, well, look, I think everyone likes to mischaracterize the other side in discussions, don't they?
Fair,
it's
very
much
fair.
easier to create a vision of what you're arguing against, this binary type of situation that you can assume what they think, you can assume what they do, and therefore you just have the argument against that. And I think most people are actually a little bit guilty of that. And, but there you go. Most of these things happen on things like social media, which are literally designed to polarize us. So look, we're all in the matrix, bro.
Yeah. I have the sense that you are someone who is very comfortable in this gray area. Right. And I think one of your areas of expertise is the biopsychosocial model, which it sort of embraces that gray area, right?
Yeah, well, I mean, again, one of the criticisms of the BPS model is it doesn't provide us direction. It doesn't cover everything. It isn't a guide to treatment. And they would be exactly right.
Mm-hmm.
It is one of the greyest areas there is. And I think that I would suggest the biopsychosocial model is more of a philosophy. than a treatment guide or an algorithm or whatever. And I think one of the issues we have is you go back to kind of people like George Engel. He was a psychiatrist, right? So he didn't deal with, musculoskeletal pain and all these things that we're trying to apply it to. So why the hell you think George Engel was sitting there thinking about what physios are going to do in the 1960s is ridiculous.
Right.
Oh my God, George Engel didn't think about physios in 2020 or musculoskeletal people in 2020. Oh my God, he's an idiot. Right? So
Yeah.
I think we go back and it is totally grey because it's a philosophy. It's saying, that human health, mental health, physical health, all across the health spectrums, disease, illness, pain, whatever you want to stick in there, it relates to more than just what happens, a cellular level or a scientific level even. It's saying human beings are complex. That's why you have things like general systems theory in there. He's saying that human beings are behaviorally driven, environmentally driven, thought driven, all of these things that we know humans to be. And, inherently, you cannot have a guide for that because everyone comes with their own individual version, We're an amazing phenotype of one, aren't we? With a million trillion variables, unfortunately. And I think that's something that really, he was saying. And I think what we've done is we've medicalized it and said, and this is what we talked about in our paper in 2022, was we medicalized the BPS model and we've tried to boil it back down through that medical lens and create treatment guides and chronic pain guide and all these other things. And it kind of loses that grey. It loses that philosophy. It loses some of its power, actually, I think.
Yeah. Yeah. So let's get into that in a little bit. But first, can we take a step back and sort of talk about, George Engel being the creator of the BPS? Where did we come from before the biopsychosocial model? And what was the driving force for change? You sort of got into it a bit there, being, the complexity of humans, but let's have a bit of a history lesson from Ben Cormack.
Yeah, wow. This is before me, by the way. I'm only in my 40s, for God's sake.
I know.
Yeah. So I think if you go right back, you got people like William Osler, and you always hear those famous Osler quotes like, listen to your patient, he's telling you the diagnosis, although he'd get shot down for sexism now. So, we have a kind of going further back than that. You have Voltaire with his kind of, amuse the patient while natural history takes its course. And, and I'm sure we could go back to the Greeks and the Romans and the cavemen and, I don't know, amoeba, right back. But I think over time there have definitely been doctors and, philosophers, if you like, that have recognised that the human condition is a complex one. And that it's, heavily driven by behaviour and by psychology. And classic example, with the Voltaire quote. And, really he's saying amuse the patient because the patient needs amusing. In the sense that we want to do something, don't we? The human being, both the therapist and the patient, they want to do something to help this, to fix this, right? But maybe the biggest driver is that natural history. So that's understanding that there's a psychological driver, isn't it, really? If you think about it, it's understanding this need to do something, this need from this psychological perspective, and we're talking... I'm going to absolutely show my lack of knowledge here. I think it's 18th century, some 17 something. But, if you think about it, he's literally alluding to this idea that human beings are more than just the problem. They are, something that has the thoughts and the behaviours around the problem, hence the need for amusement. Right?
Yes.
And so, this is just human philosophy, isn't it, I suppose? And, we've had other people like Peabody, we have John Lucer, we have Melzack, and, all of these other people that have come at similar times. And all of them, I think, have given a wider perspective of pain, away from just this pathology, transmission to the brain output, as we might see from that classical pain theory, the kind of Descartes and that kind of thing.
Right. It's interesting because to me, the biopsychosocial model, it's a lot about this holistic approach and looking at the whole human and embracing complexity. And that holistic approach seems to be heavily ingrained in traditional Eastern medicine. But Western medicine for a long time, I think, was in the biomedical model, right? Which is more of this reductionist type thinking where everything is ingrained in the biology and not as much in the psychology and the sociology. And you just fix a broken part somewhere and then the problem is fixed. And I find it interesting because it seems like now Western medicine, by embracing the biopsychosocial model, there's sort of now this blend happening between Eastern and Western medicine. But do you think that's an accurate way of looking at it? What are your thoughts on that?
Well, I think it's inaccurate to say that we are beyond the biomedical model. I think that we are seeing some embracing in our echo chambers, right? I don't think at a systemic structural level within health services, within insurance-based practice in whatever, I still think we are driven mostly 99% of the time by the biomedical model.
I agree.
Surgery, yeah, absolutely. But I think sometimes we can listen to our echo chambers and think, at least there's discussion happening, right? That's brilliant. Let's embrace that. Let's look on the bright side. But I still think, the amount of people that I see that have been, damaged by overdiagnosis, overtreatment, unnecessary surgery, these type of things. Still, I always say, when the pendulum will swing, when someone comes into me and says, Ben, I want some of this biopsychosocial shit. When someone says, I had it today, I had someone email me and say, I can't remember what they said exactly, but something like, I think I need my leg length checked. And that is a great example. When someone emails me and says, I think I need my pain self-efficacy checked, I will probably say this model has swung. So look, I understand what you're saying with this kind of idea of Eastern medicine. And I think a lot of the time that embodies it thinks about the idea of the spirit as much as anything else, which I think is another way of looking at psychology or human beings or whatever. Sometimes that's shrouded in this kind of mysticism and superstition, which I think can be problematic as well. But
Agreed.
It is also looking at something. So the only thing I'd say, sometimes Eastern medicine, I think, is maybe not giving the locus of control to the person, because sometimes it's about this idea of spirituality and coming outside of us, which I think actually when you talk to clinicians in Africa and things like that, ideas of things like witch doctors and stuff like that are still really, really prevalent, actually.
Wow.
We had Martin on from Kenya on the BCP, and he deals with these kind of, tribally, kind of villagey type of things all the time.
Wow.
And people actually have a distrust of medicine because they have this idea about, something more spiritual or otherworldly. And I certainly think that it's good to see it holistically, but maybe it also has its problems in slightly different ways.
Right. It's probably a little bit better to meet somewhere in that gray area, right?
100%. And I think the point of the BPS wasn't to replace the biology. It was to go beyond the biology.
Right. I find it interesting that you're saying there's that distrust a little bit in the Eastern medicine, when it seems like on the Western medicine, a lot of the time, it's the complete opposite, where people will trust whatever a doctor says to them. And I do agree with what you were saying earlier, how we haven't moved past the biomedical model. And as you were mentioning, systemically, we see that, but culturally, we definitely see that as well. Like when you were saying someone emailed you asking for a leg length check, That is something that's ingrained in the biomedical model. So I feel like people still have a very big trust in that. Like you just need to find the root of the problem and tighten up a loose muscle or strengthen a weak muscle, or find, the asymmetry or the imbalance, and then you're good to go. Or get a surgery, that fixes a broken part.
But I get it. I understand. Why would you not want that? If but people talk about, to me, patients come and they expect this treatment or they expect this from me. But people only expect what they've been sold, right? So over the years, people have been sold, treatments where they just lie down, head in the hole, and get rubbed and poked and prodded and pinned and infrareded and whatever else crazy shit people do, right? And if you I visit a lot of countries teaching. If you go to Italy and Spain, there's still a lot of kind of driving of kind of electrotherapy variations. I was introduced to a machine the other day called Tekar therapy, I think, which was of a passive type of thing. I'd never heard of it. And apparently it's all the rage. I can't remember whether I was in Spain or Italy, but I can't remember my children's name either. So, right, and it was, to me, I've never heard of it, and it just shows that I think, a lot of countries that I go to, people still don't believe exercise is a treatment. That's not what physio or any kind of MSK treatment is. It's passive treatments. That's what people come for. And I think that, the problem with that is that this is what they've been sold. This is the way the systems work. This is what the doctors ask for. And, there is this idea of the body as a machine. If we go back to kind of 2017, there's a great Jenny Setchell paper looking at patients' beliefs about their body. It was something like 90% of people with chronic pain think that their body's like a broken machine that needs fixing.
90%?
Right? 90%, I think it was as high as that. And I hope I've got that, but I don't know my children's name, so I'm not likely to get the percentages right either. So there's a bit of a get out.
I almost spat out my coffee there.
Yeah. There we go. Got to have comedy in rehab.
Of course.
So, so I think there's a perception of how the body works. It's very mechanical. There's a perception of what treatment does, which is fix that mechanical problem, and you are good to go. Find the muscle that needs activating. Find the muscle that needs lengthening or strengthening, put the thing back into place, identify the thing that needs to be cut out. And at the end of the day, that makes mechanical, intuitive sense. Why would you not want that if that's what you've been sold and that's what you've been offered? And that drives the machine, the money machine that healthcare can be. And I always say back pain is actually a societal, systemic problem, not actually probably a problem of pathology. It's more likely to be a problem of societal belief and what we think the problem is and how it's going to affect us and what we need treatment to be, rather than an actual pathological model where we identify something and then do something about it. And and I think that the thing about the biopsychosocial model is exactly what it's trying to do is expand that, right? And we talk about, the fact that you bring this up shows that we haven't moved as far as we think. In our circles, no doubt, we're discussing it. We're bringing these ideas. If you actually look at what gets likes and shares on social media, it's almost always pathological or biomechanical. And that's why those type of people have 1 million followers, because it's intuitive, it fits into the system, it fits into what we see as our paradigm, our hegemony. And I think that until that changes, there's your problem.
Right. Yeah. When you say within our circles, that doesn't even mean the physio circle. That means within this subsect of physio. Because anecdotally, and I'm wondering if if there's any stats on this, but a lot of the clinicians I've spoken to or have been under or seen as a student, or just the stories that I hear, a lot of it is from physios that are still ingrained in the biomedical model and this patho-anatomical model, this something is broken and needs fixing model. And it's not just, surgeons that are doing surgery. Like, all healthcare practitioners, I think, are, I don't want to say guilty, but have, no one is exempt from still being stuck in this model. I think when you look at the professions as a whole, I went to the dentist recently. I hated it. I was spoken at too, and like I wasn't treated as a person. I felt like I was a number. I didn't feel like the guy cared for me, and because of that, because I have the health literacy and the understanding of what a proper relationship with a healthcare practitioner should look like, which is one where it's collaborative, I didn't even trust what this guy was saying to me. I felt like it was a money grab, and I'm sure it wasn't, but it's unfortunate that that's how I felt, because I didn't feel like I was being cared for. And this guy, he hardly looked me in the eye.
Yeah, look, I mean, I think dentistry is sometimes a different example, because, there often is an identifiable thing we can cut out or fill or something like that. And I think that means that things like therapeutic alliance are probably less necessary.
Fair.
I think if we look at the world of pain, look, this is examples I use when I teach on my course. If we think about blood pressure, we can identify specifically high blood pressure. We have medication that people don't always take, by the way, but we do have medication that brings it down. If we take blood sugar issues, things like diabetes, again, we can measure blood sugars. We have drugs that help, insulin that helps, manage that. When we look at pain, especially chronic pain or persisting pain, we don't have a measure of pain apart from a subjective report. We don't have, clear things to do. So we don't have drills and fillings, right? So this is what makes it so difficult, is because we can only work on subjective reporting. We can only, half the time, we don't actually have a very reliable idea about what's causing it, right? So, type 2 diabetes or type 1 diabetes, again, there's going to be some variance, but I think we probably know what the drivers of those are to some degree. So I think one of the problems with pain, and why things like this kind of therapeutic alliance and this kind of humanistic approach is so important, is because we actually lack many of the things that other people have. So we don't have these things that enable us to do it separately from the human being. If I'm a doctor, I can bring you in, I can measure your blood pressure, I tell you to stop smoking, stop drinking, do some exercise. Hopefully your blood pressure goes down. If not, I give you some drugs or you die. It's fine.
Oh,
right?
God.
Right? But it's your choice, isn't it?
Yeah.
Right?
Yeah.
But I think with pain, you come in, I don't always know why you've got it. Often to get rid of it, there needs to be something to be done, like a behavioural change kind of thing, whether that's, if we think about the BPS model, how much of that is behavioural change? So we've gone from this, find it, fix it model to this unbelievably complex behavioural model that, is really, really difficult. And I can understand why that is hard to implement. I really, really do.
Yeah.
But I do think part of the problem that we have, and why we are so reliant on relationship, is because pain isn't really a medical problem, if that makes sense, in the sense of I can measure it, I can fix it. There are times when it is more medical. There are times when it doesn't seem to be medical at all. And I think that provides a really, really big problem, and why all of those things you talked about are really important. Maybe I'm just going to come to the defense of the dentist, maybe, that, I think they're probably slightly skewed more towards the find it and fix it model, because it is a bit more like the find it and fix it model. Unfortunately, that paradigm isn't where we sit.
I see. It's an important distinction. Thank you for making that. Maybe I'll be nicer to this guy in my brain.
No, but the point is, if you go into an A&E unit, do I need that guy to, obviously I want him to be nice to me, but also someone who's going to make life and death decisions, right? And that needs to be independent of people and emotions and these type of things. Right. I don't get into many life and death decisions with people. In fact, like none really, apart from myself. And at that point, it's always interdependent. It's never independent. And I think that's what people need to realize about pain. It seems to be a very interdependent thing, not an independent thing like health decisions. Is in terms of, should I cut this guy's leg off, or do we need to operate on this, or do I need to, do something like crazy, right? And we need to make that distinction between what we do and what other people do, potentially.
It's a really good point. So you were saying that back pain is almost a societal problem, and it might not be as, do you think it might not be as much of a medical problem? Diving into what you were saying before.
So when we say medical, I suppose maybe we should call it pathological. Maybe that would be a better description,
Okay.
In terms of medical intervention, in terms of injections and all those type, operations and those type of things. I would class those as being more kind of medically driven rather than just dealing with a painful problem. But yeah, if you think about, is physiologically, there's an Amanda Hall paper from 2021, and they had a little section in it, and it said, and I always ask this question in my class, it says, back sprains and sprains are much like ankle sprains and strains, right? They recover quickly. They have a low low chance of being medically serious. They have a low chance of X, Y, and Z. You don't need to scan them, etc., etc. And I always ask people, do you think that's true? Now, apart from the anatomy, if we look at pain, isn't anatomical, is it? It's physiological. If you think of the process of nociception, that is a physiological process, not an anatomical or structural process.
For those who don't know what nociception is, can you quickly just let them know?
Nociception is the activation of receptors that sense noxious stimulus. So essentially they are thermal, chemical, or they are mechanical, and they sense high threshold information that's likely to present a problem, a danger, a threat, whatever, right? I don't want to get too much into that because then we start to get skew-whiffy. Right? We start to get into a philosophical debate all on its own.
Yeah.
And, so these things are generating nociception, and then we obviously perceive that as a painful problem or not a painful problem. There's pain science 101. And so physiologically, nociceptively is an ankle problem much different from a back problem. So nociception might come from different structures. So, again, we talk about, do structures heal, what kind of rates, etc. But essentially, physiologically, nociception, is it any different in one structure to another structure? That, there's a little debate. And I think you could probably say, there are a lot of similarities. So, and we talk about nociception in quite general terms. So if, what is the difference between an ankle sprain and a back sprain? Well, I think a lot of it is perceptual. If we think that most back problems have a good prognosis, so they'll probably recover quite dramatically in the first couple of weeks, and they might linger for another 2 to 6 weeks. Around 25% do go on to become chronic or persisting, but that is episodic, not kind of, back pain has its own kind of natural history or trajectory to it. But, maybe the difference is our perception of that nociception or even the painful problem, the perception being, this is problematic. My Uncle Ken had chronic back pain for 30 years and he couldn't work. My Auntie Gillian was in bed for 5 years. Is this going to affect my work? Is it going to affect my, relationships, my family? What's my outlook for the future? I'm getting depressed and I'm getting anxious, and there does seem to be a lot more of that involved with back pain than other places. So from a physiological standpoint, how different are they? We could debate that. From a kind of psychosocial, societal standpoint, I think they're perceived differently. And I think we do seem to have quite a lot of other prognostic factors that affect outcomes. When we talk about pain self-efficacy and we talk about, anxiety and depression and, fear avoidance and these type of things. It doesn't mean that they don't exist other places. And we know that people have researched this a lot, even the foot and the knee and the shoulder. But it still seems to be, for me, my interpretation, that back pain tends to have more of a societal negativity to it, or even an individual perceptual negativity to it that doesn't come with other body parts.
That's a really fascinating point. Both ankle pain and back pain, they are one and the same because they both arise in consciousness. And that's why it's an issue, because either way you paint it, people are experiencing this unpleasant thing.
Yeah.
But the state of mind, the state of being is a little bit different oftentimes when it comes to back pain, because people have so many scary beliefs about it. Right?
Yeah, well, and this is nothing new. You know, John Lucer talks about these kind of things where he has his onion skin. You know, we go back to Norton Hadler, you know, talking about the idea that, you know, when it comes to back pain, we seem to be societally a lot less accepting of having back pain. You know, this idea of pain self-efficacy. So my ability to do things despite of pain, or my desire to kind of not have to seek care or not have to seek treatment. And we see some recent research for, I think it was De Campos, and they looked and they found that I think the average in the community, the average length of time of back pain was 5 days. When people went and got treated for back pain, it was 19 days.
Wow.
Now, could it be that people who have more pain go to seek treatment? I think that's a fair hypothesis. I'm fine with that. Could it also be, though, getting treatment can actually make the problem worse? We have this idea that treatment makes things better. But, you know, we also know we have a word I hate saying, iatrogenic injury as well, where we know that we have over-medicalisation, we have over-treatment, and these things do have an effect on people. So I don't think we can always say that treatment is a positive, right? Getting treated could relieve pain. Could it actually cause pain to go on for longer? You know, we don't consider that enough. So, you know, I think that we need to balance this idea of feeling the need to do something and helping people, and actually, is there a negative effect from that? And if anyone isn't considering the negative effect from too much treatment, then I think they're being very short-sighted and a bit egotistical, if I'm being honest. So treatment can help, no doubt. Can we have too much of a over-treatment? I think so. Can we have too much of the wrong types of treatment? You know, I think that as well.
Right. Being a new graduate, a lot of newer graduates or students sometimes ask me, you know, how do I maintain a caseload? And while they are passionate, caring physios, they also have a concern about making money. And I think this is a concern that I have, because some people, if someone comes in with an acute case of back pain, that after you rule out red flags and you deem that, you know, it's probably going to get better. Obviously, we can't say that with 100% certainty, but if you think it's a favorable case, there are potential harms of keeping someone in your care for too long. Even if you think it's harmless, it might not be sometimes. So we do have to be careful with that, right?
Well, if you are a critical thinker, you must consider the negative as well as the positive effects of any treatment, right? So I do not think that, you know, I think that I don't actually think that treatments create dependency. I think therapists create dependency, right? And I think sometimes people do it inadvertently. And for some people, it doesn't matter. And for other people, it really, really does. So if we're not considering that, I think that's a problem. So sometimes my main consideration is, should I get out of the way? Am I going to make this worse?
Yeah.
And I think if you're only thinking sometimes I've got the key to make it better, then again, I think that kind of comes across as a little kind of, you know, narcissistic sometimes. It's not a very person-focused thing to do. I think sometimes, you know, I think there's an idea of treatment. You know, if you don't treat people, you're not person-focused. I actually think the opposite. Sometimes if you treat people too much, you're not being person-focused.
That's such a good point.
But why not? If you consider it from one end, you have to consider it from the other as well. So, you know, I think that's the problem with back pain, is it's difficult. We have people, they've had years of back pain. They want something done to them. And so there's a desire to do some kind of treatment, symptom modification, whatever. But there is also a negative side to that. And whether you want to consider it or not is up to you. But I think it has to be considered. Now, some people would sit on one side and say, well, if you're not helping with this person's pain, you're not being a help. How many people have gone to see a chiropractor 5 times a week for the past however many months or years? So that's exactly that, isn't it? Have they been helped or have they been harmed? So again, it's a balance, isn't it? And I think these things are a spectrum that sometimes we need to do something and sometimes we need to get out of the way. And that's probably called clinical reasoning.
Yeah. I've heard this argument.
And it is a balance financially. But if you want to drive a Ferrari, go and work on Wall Street, sell drugs, I don't know. Right? Unfortunately, I don't always know if healthcare is the place for that.
Right. You heard it here first, folks. Go sell drugs.
Basic economics, right?
Yeah. Go sell drugs on Wall Street. Probably make pretty good money there.
That sounds like a recipe to make a shitload of money, brother.
I think so too.
Yeah. And it's probably a lot easier than doing 100 manipulations a day.
Yeah, easier on the hands.
Yeah, well, until you get arrested and thrown in prison, and then God knows what will happen. But anyway.
Right, I didn't sense any cons until you said that. So thanks for pointing that out.
Noah was out the door. He was like gone. He was thinking, "This is my career path. This was an epiphany."
Yeah, I'm done with the podcast.
Yeah, exactly.
What am I doing here?
Exactly. Next stop, Colombia.
So I've heard the argument that back pain can be a little bit like the common cold. And the argument there is that, a lot of people get the common cold. When you get it, you just try and be a little bit healthier and you try and get on with your life. You recover a little bit and you just try and move past it. People don't really catastrophize and think that it's the end of the world. Now, there are cases, of course, where back pain is way more severe and complex and doesn't just simply go away like the common cold. But in general, how do you feel about that statement?
Yeah, I think sometimes the problem is it minimizes it for people, doesn't it? It's a bit, I think, I have a little saying. It's, back pain is often not medically serious, but it's seriously painful. And what I want people to know is that, this thing is unlikely to kill you, which is, people have a common concern that it is something serious, but also not kind of invalidate this painful experience. But we do see a lot of parallels with the common cold. How many people go and say, doctor, give me antibiotics, right? And the doctor's like, well, what the fuck are they going to do? And I think sometimes it's a bit like over-treatment for back pain. It's like we want something because we think there's something out there that's going to help. And I think, a lot of the treatments that we give people are a lot like giving antibiotics. They're a bit ineffective and they have a social problem, don't they?
Yeah.
So it's kind of, there's this thought of, I'll just give antibiotics. There's no harm. What's the harm in it? Well, there's this harm of immunity. And it might be that with back pain, what's the harm? I'll give someone this treatment. Well, the harm is societal, that now people expect those treatments. So I think that, again, I think one of the problems is the idea of people I don't even know if you've got a common cold if you try to be healthy. You just I eat shit and lie in bed. I'm just trying to get through this thing, right?
Yeah.
For me, I think the analogy is a good one. And there are a lot of parallels. Sometimes people go to the doctor and say, but I've had this cold for 3 weeks. A lot like back pain. Is it normal to have back pain for 3 weeks? Yes. Is it normal to have a common cold for 3 weeks? Yes. So sometimes we're like, well, I've never had it for this long before. Well, that doesn't mean it's not normal. You just haven't got a big enough of a sample size.
Yeah.
But I think one of the problems with this idea of the common cold is it maybe minimizes it for people, that they're like, well, it's more than just a common cold. I need more than just a Lemsip or a whatever kind of paracetamol drink. That maybe it can be disruptive, especially when it becomes a little bit more chronic or persisting and it has that trajectory of flaring up every 3 months. So most people get a common cold once a year. Some people do get recurrent long-term back pain. So I think the parallel is a pretty good one in about 80% of cases. I think 20% of cases, it probably doesn't apply very well.
Mm-hmm. And I do love that saying that you have. I've never heard you say that before, but that back pain is not serious medically, but seriously painful. Is that it?
Yeah, that's my saying. So
yeah,
if you
can I take it?
Else, it was mine.
Can I start using that?
Brother, you can use it. Every time you do, you have to send me via PayPal $1 Canadian.
There's a royalty on it. Okay.
Yeah, it's a royalty. There's a fee to pay, bro.
Yeah. Well, I guess thank you for letting me pay in Canadian, because I guess the exchange it's favorable, right? The pound's more than the dollar, isn't it?
The pound is more than the Canadian dollar, yes. Although when I was just in Vancouver, it seemed pretty expensive to me, but there you go.
Yeah, well, that's Vancouver and Toronto.
There you go. Yeah, there you go.
So you've mentioned a few fancy words earlier on so far. You've spoken about self-efficacy. We've spoken about fear avoidance. What are these things? Why do they matter? And yeah, can you give us a little bit of a background on those?
Yeah, so pain self-efficacy is just being able to do things despite pain, right? And I actually think in most cases of musculoskeletal pain, we need it. Because even if you go to see the best physio in the world or the best chiro or the best osteo, their success rate of taking away pain 100% of the time, they will tell you they can, but they're lying. We know that it's very, very difficult to just take pain away. So all musculoskeletal problems require some element of dealing with pain, don't they? Of being able to live my life with pain. So what we know about back pain, from work by people like Nadine Foster, and if we look at shoulder pain with Rachel Chester's work, etc., we know that pain self-efficacy seems to be a prognostic factor. So it affects outcomes. It affects the prognosis, the history of the problem. So therefore, for me, it becomes an important thing, right? So people with low pain self-efficacy that avoid pain and have avoidant behaviours seem to have worse outcomes. So it seems to me and again, going back to Norton Hadler and his work in the 90s, pointing out that we are more pain averse. And I think, that's because we're told that pain is something dangerous. It needs to be fixed. You need to pay me to fix it, or you need to see the doctor, or you need to see the physio. That's the damage of that message, is it creates a pain-averse society. And I think we've reduced, and I don't want to place any blame on individuals. This is a societal problem. I think we have, if you go to the US, they all advertise painkillers on the TV. You can't advertise drugs anywhere else in the world, by the way, because it's problematic. Because, it creates healthcare problems because you're choosing the drugs that you want when you should never be able to do that.
Yeah.
So, again, societal problems via money. So I think that's the big thing is we are becoming, I believe, people who are more worried about pain. And the more worried about pain we are, I think the more problematic that becomes when we have pain. And if we look at, for God's sake, if we rewind 500 years, life was about suffering. The more suffering you had, the more likely you were to get into heaven.
Yeah.
So it shows how societal beliefs change, right? So I think it's really important that we recognise that sometimes taking pain away or always trying to take pain away is problematic. And again, another thing that I talk about on my course is this idea of incongruence, whereby we'll give people messages like hurt doesn't equal harm. But as soon as someone has pain, we'll say, stop doing that. Or jump up on the bed and I'm just going to massage that or manipulate that or get rid of that pain. Or I need a window of opportunity whereby I manipulate you first and then you do some exercise, right?
Yeah.
Can you see all of these things lower our perception of pain as something normal and tolerable? Now, is there a dark side to pain self-efficacy? Well, stress fractures, overuse injuries, people whose psychology is far stronger than their, physicality, if you like. So it's a U-shaped relationship whereby too much low pain self-efficacy is a problem, a bigger problem than high pain self-efficacy, I believe. But I think high pain self-efficacy is less prevalent, especially in our comorbid chronic populations that are probably a little bit more damaging from a societal perception. So cost on society, that type of thing.
Yeah, maybe a bit higher in some athletic populations who just want to push through the pain.
Yeah, but then they also tend to be higher socioeconomics as well with athletic populations. So again, we have to weigh up some of those societal aspects as well.
Right. I want to get into that in a second, but let's say someone comes in with some low self-efficacy. Now, I know there isn't a blueprint for this, as we've discussed. Everyone is different. Do you have any strategies of how you try and boost someone's pain self-efficacy? I mean, I assume one of them would be not trying to take away their pain all of the time. Not that that's necessarily a bad thing. But
yeah, so, I mean, first, I want to know what are their beliefs around pain? You know, so what kind of treatments have they had before? What do they believe is causing their problem? You know, remember, this is a belief-based issue, a behaviour issue. So I want to know maybe what's driving some of that behaviour. And from that, you know, again, it comes back to listening, therapeutic alliance, trust, all those things that make everything tick. So I want to understand a little bit more about this person and their perceptions of their problem, maybe what's driving some of those things, some of those beliefs. I think this is where we are, you know, this is where we're kind of exposure-based stuff comes into play, where we're challenging or working with some of those ideas and concepts that people have about their bodies. We're giving education, but also experiences to back up those type of things. What I like about exposure-based stuff, I think it's physical and it's psychological together. And for me, I think that's important because humans are physical and psychological together. And I think that's the BPS model a little bit, isn't it?
Yeah.
Bones don't move themselves, muscles don't move themselves, nociceptors don't, you know, interpret themselves, they don't make decisions on behaviours and those type of things. And I think for me, it's working with people's beliefs, sometimes against them, sometimes with them. It's creating it and understanding this person and why these things exist, and then creating experiences that help break those things down. So we could say a blueprint, but, you know, can you imagine how many things drive those beliefs? How many things drive those behaviours? How many different contexts those behaviours happen in? You know, some people might say, well, I just make people lift heavy shit and their fear goes away, which is just bollocks. That's not how it works because, you know, we know that these things are contextual, they're specific, they're not general. And I think that the person always has a bit of a key to that. Not an exercise or not a technique or you know, it's the context that's the king, I think.
Right. And speaking of the context with exercise, when I'm working with someone with chronic pain and maybe they're a little bit fearful of a certain movement, again, going back to what you're saying before, I'm trying not to have any incongruency where I'm saying it's okay to move, but when they try and move, I'm showing that I'm fearful.
100%.
Right? I'm in the context there. I'm trying to encourage them to move, and I'm showing them through my body language that it's okay to do this. You know, I think this is safe. So I think that's an important context that a little role that the therapist can play there.
Well, I think it's a huge role. And at the end of the day, we know that therapist beliefs influence patient beliefs and influence patient behaviours. So that can be body usage related, it can be work related, it can be activity related. There was a piece of research, I think 2019, where they used something called the biomedical orientation score. I don't really know what it is exactly. There's 1,000,001 outcome measures out there that they use.
Yeah.
And what they wanted to do with that is find out if you have this higher medical orientation score, how that relates to people's behaviours. And the higher the biomedical orientation, less return to work, less return to activity, you know, these type of things. Your behaviour as a therapist is a massive, massive driver of what your patients will do.
Yeah. And it's not just the words you say, right? There might be some, and I don't know if there's a ton of research on this, but it just makes sense intuitively that there's also nonverbal stuff going on there. Your tone of voice and your actions, and if you show hesitancy.
why does pain education not have a big impact? Because it involved education, from a verbal standpoint, from a cognitive standpoint. We need experiences, we need actions, we need things to say, oh, actually, what Ben said, this is okay. Not just Ben said it, but I don't really believe him, I'm not going to do it. I think you could actually measure pain self-efficacy via probably behavioural measures better. So is this person engaging in things they were fearful of? I can tell you I'm not fearful, but until I'm engaging, that's probably a true measure.
Right. That's a great point. So pain self-efficacy, it's the psychological factor, as you've mentioned, influenced by sociological factors, right? Societal beliefs and societal problems. So that might be more of a psychological component that plays a role in someone's experience of pain. But there's also ones that are more entrenched in the social realm, the social determinants of health. And you mentioned this earlier when I mentioned athletes, and you're saying they're from a higher socioeconomic status. So what are some key social determinants of health? And is there anything, again, that we can do as therapists to help someone in pain when there are some key social determinants of health that are involved in their experience?
Yeah, so I think there are things that are modifiable, and I think there are things that are non-modifiable, right? So non-modifiable things are probably your educational status. Non-modifiable things might be things like childhood trauma. Non-modifiable things might be housing or job or family, right? We can't change that. But I do think we can be aware. And I do think, if I have someone who I think is, it's really, really difficult, isn't it? Because I think there's always a desire to do something, to, in some way have a fix for everything. And these things do not have a fix. But can we be aware of that in how we work with people, what we ask them to do, resources that we point out? So if I have someone who I think is lower socioeconomic status, maybe they use educational level as a proxy for that, or what about this person. Am I going to ask them to engage in a Pilates class at $50 a time? Am I going to ask them to skip their second job to go and do exercise? Do you see what I'm saying?
Yeah.
How does it fit into their world? So it's not about solving someone's socioeconomics. It's about appreciating who this person is, how their socioeconomics might affect them, and how that integrates with what you are trying to do as a therapist. You cannot, they're non-modifiable. If I could give everyone money, I would do it. I really would. As long as I still had loads of money, though, because I think that's how altruism works. Right? Yeah. I had loads of money, then I give some away. And then I still have loads of money. But
maybe you should play like a Robin Hood role, go to Wall Street, sell some drugs, make some extra money, give it to the patients.
Fine.
There you go.
It's fine. Here we go. Excellent.
Nothing wrong with that.
And no one will go to prison for that. And from my perspective, it's an awareness. That's the BPS model. It's not about finding it and fixing it. It's not about identifying a socioeconomic problem and finding the fixer or it being the driver of pain. I don't know what influence this is having. I have no way of finding out. But I do know you're experiencing it, and I do know that at some point I should think about that within the context of what I'm trying to do. It's a philosophy, not a find it and fix it model. And that's the problem there in a nutshell, isn't it? Now it's like, oh my God, I'm a therapist. I can't do anything about psychosocial factors or socioeconomic factors, so it's worthless to me, right? It's the biomedical find it and fix it model. No, you need to be aware. You need to understand. You need to think outside of your perspective and your box. It's about a philosophy of other people, not just a philosophy of myself and my desire to flick a switch and fix the world. That's not how it works.
Yeah, it's about being aware of all these things and how they fit into the bigger picture. And I feel like oftentimes the BPS is misconstrued to be 100%. Like, oh, if I can't find a biological factor, then their pain is all in their head and it's because of their beliefs. But that's just redirecting this find it and fix it issue to yes. That's a good way of looking at it.
Yeah. So what people have done is they've taken this BPS model and they have not changed their paradigm. What they've done is they've viewed it through their own philosophy and paradigm, right?
Yeah.
Do you see? It's not like this, oh my God. And people talk about moving beyond the BPS model. We haven't moved anywhere near it quite yet, right? And so that's the point. It's not the find it and fix it model. I'm going to find the driver of your pain. It's your socioeconomic status, and I'm going to fix it. Well, it doesn't work like that, right?
Yeah.
It's an appreciation. It's an awareness. It's a humanism. It's a broader perspective that these things matter. I can't always do anything about it, but I can appreciate it and I can work with it and try and help people in some different ways. Social prescription is a great example. How do I find resources for this person to get healthy at much lower cost? What is available in society for us to do that? Taking a broader perspective.
Right. There is something you can do about it, but it's not about fixing their socioeconomic status.
It may be about resource. It may be about identification. It may be about education, not fixing it. Again, it involves the person, not you.
Right. Getting your ego out of it a bit. Ben, I know you're really busy. Do you have time for one more question?
I have time for you, my brother, always.
I appreciate that. So you said that there's talk about moving beyond the biopsychosocial model. And yes, we're not there yet. We haven't even properly ingrained it yet. But although we might be getting ahead of yourself, do you think there are any holes with the BPS? Do you think that anything needs to change, or can you predict that there might be a new model that we might use at one point? Because our beliefs as a society are always changing.
Yeah, again, as society changes, will we see a need for something different? Something that reflects the changing society? If we went back to the medieval times, has society and needs and philosophies and all of these things change? It's the world. And this is what annoys me about people who don't want to change their practices. You want to drive the most modern car. You want the most modern drugs. You want the most modern surgeries. But I still want to be doing the same manips I was doing in the 70s, right? Again, we want evolution in some ways until it comes at a cost for us, learning and changing practice and those type of things. So, yes, I believe there are a huge number of holes in the BPS model. I do not think it explains everything for everyone all of the time. Inactivism is another model. Great George Box, what did he say? He said, all models are wrong, but some are useful. And, we just have to roll with it. Look, Melzak's pain models, Lucer's onion skin. We have all of these different ideas and, Pat Wall's work, McMahon's kind of, immunology work. There are so many paradigms and ideas, and sometimes we're looking for too much of a unifying paradigm, one that explains everything to everyone all of the time. And we need to accept that there are different ideas, there are different theories, we can debate and discuss them, and that's okay.
Yeah, brilliant. When doesn't it work? When is the BPS? When is it not applicable? I guess maybe what you're saying before. Maybe sometimes in dentistry it's not as relevant.
Well, no, but that's biology, isn't it? Then it works because it's encompassing biology.
So see, that's my struggle with this, because when I think about the biopsychosocial model, it seems like it involves everything. So I'm struggling to see its holes.
Yeah, well, I suppose where it falls down maybe is when we try to apply it as a treatment model. Philosophies are different to models, treatment models, aren't they? And I know Engel called it the BPS model, but he also called it a framework. We wrote that in the paper that me and Peter and Joe and Sabrina wrote. We wrote that. I think there was a paragraph. I haven't read it for a while. And it's long and boring, probably. So, and full of what did Paul Ingram say? It was full of fancy $5 words, which was a good turn of phrase. It's probably way overcomplicated. But I think Engel called it a guide for practice, a framework for research, I think it was just seen as it could be used in lots of different ways at lots of different times. Am I wedded to the BPS model? Hell no. Am I wedded to anything? Not that much. So at the end of the day, could there be something that comes along that gives better ideas? Are there other things that do good jobs of giving other ideas? You know, I named an activism, for an example. No one knows what an activism is, but that's totally fine as well. Right? So we have all of these ideas and philosophies and contextualism and applied contextualism and unapplied, you know, all of these theoretical, you know, pragmaticisms and, you know, it's great. It's just lots of different philosophies. Some of them are separate. Some of them overarch. Some of them are quite similar. Some of them are different. And, you know, we're going to gravitate towards some more, away from some. And that's the nature of thinking, is that how can there ever be a unifying philosophy with the diversity of people?
So are you saying things are complex?
No way. Things are really simple. I have totally over-egged the pudding here. But yeah, no, but I think one of the things that I think is we have this idea that there's an answer, that there's something out there. We talk about patients and we say they're inflexible, psychologically inflexible. They're looking for this answer for their problem, this one muscle that needs to be activated. Therapists are no different. They are looking for unifying answers. They are humans in the same way. They're just looking at something different. And, you know, tolerating the fact that there are lots of different ideas, lots of different schools of thought, lots of them have merit, lots of them have holes. That's why you're a lifelong learner, isn't it? That's why, you know, that things come up all the time. And I'm like, I've never fucking heard of that. Where have I been living under a rock? But as soon as we move to a place, I think, whereby we're accepting of lots of different ideas, sometimes we're trying to put things in boxes a little bit less. We understand and appreciate the diversity of people, the diversity of cultures and, you know, philosophies and ways of thinking. It starts to make the world a more sensible place to live in, because it's not about the one answer that unifies, the one ring that rules them all, right? Because I think that idea causes a lot of problems, that I've got the answer, you need to learn from me, you know, you need to come to me as a therapist to fix you because I have the answers, because I learned from Johnny Who back in the 60s or whatever bollocks. And at the end of the day, I think if we're a little bit more tolerant of that, there are lots of schools of thought, lots of them have merit, lots of them have holes, maybe we'll move towards a bit of a middle place.
I think that's a beautiful place to end today. What do you think?
Yeah,
cool.
Good for me, brother.
All right. Thank you so much. I thought that was really, really good. I learned a lot from you, as I always do. Ben, where can people find a little bit more about you and what you do?
I am very shy. Very difficult to find me.
Adam said the same thing.
Yeah. He's probably stolen it from me. Most of the things that Adam said were stolen from me. So no. Obviously, I like to engage on social media. Not as much as I probably did 5 or 6 years ago. You can find me on Twitter and Instagram and a bit on Facebook. And, you know, I like to voice my opinions. I'm not shy about that. And some people like them and some people don't.
Well, I love them. And also Better Clinician Project as well. And Cor-Kinetic.
Yeah, absolutely. Right? So the BCP obviously is mine and Adam Meakins' kind of platform. And we just want to give good advice about helping people, from lots of different perspectives. And we have some great guests and we do some kind of clinical examples and talk about the evidence and give some rehab examples and just approach it from a very sensible perspective. You know, what does the evidence say? What do we think about that? And how can you put that into practice?
Awesome. Okay, Ben, thank you so much.
Thank you.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.